Let's move on then to item 15, which is the CCG Development Framework. Ros.
Thank you, Chair. So this paper sets out some work that we've been doing with CCGs about how NHS England and others can support CCGs in their development. And CCGs as new organisations, we recognise that authorisation gave them a sort of safe threshold to operate, but to deliver the challenges that we face, that there's a further development journey for CCGs. We've done it together. I'm very grateful to Nadeem Fazlani, who's the clinical chair of Liverpool CCG, who's been co-chairing the development working group with John Buick from our team. And we've had over 160 CCGs be involved in putting this work together. I think the three things I would pull out from it are, first, it's built on insight and analysis about what are the biggest development needs in order to meet the challenges that we face. Secondly, we hope that it enables, if you like, suppliers of development support to put their efforts in the right place, so not spend time putting offers into the market, which aren't the things that the system most needs. And thirdly, it will begin to guide us in NHS England about how we ourselves provide support to CCGs, whether that's through directly helping, which as we went through authorisation, in some parts of the country we have been giving direct help to CCGs, but also in facilitating networks in order that you get peer-to-peer learning, and in guidance and bringing kind of international knowledge and insight to bear. So this work, it's not set in stone. It's we continue to work and develop it in light of the context as it changes. And the board, I'd like to invite the board to sort of comment and endorse the approach set out.
Comments? Kieran?
Fine by me. I think it'll work.
If I can just ask a slightly more open question, how are CCGs feeling? And how are they feeling about the relationship with their local area teams and with NHS England, etc.?
Well, I mean, I don't know if Barbara wants to comment on the area teams. I'd say at a national level, we've put a lot of work into building a shared view about how the relationships would operate. And last week we published the kind of values that would underpin our working relationships in, if you like, the three areas that we work, so assurance, and oversight and development and co-commissioning, because sometimes NHS England are sat alongside CCGs in discussions. What we've found is that some of the, if you like, the practical issues of transition, that working through that over the last 6 months, that just there's been that time which is inevitable, I think, in new systems of people getting to know each other and understanding how to work together. And I think we continue to work on that. We are doing a 360 survey, so NHS Clinical Commissioners, the national body, will be doing a survey of CCGs to tell us what they think in the autumn. So then the board will actually have some very concrete data as part of our sort of organisational health. So it'll be more than anecdote.
I do think this is good. I mean, I think everybody knows how critical, in the light of the conversation we had about the spending review, that this is where the tyres hit tarmac. So it's mission critical that we get it right. And the extent to which CCGs, to some degree, don't know what they don't know, if you see what I mean. I mean, some of these people are taking on leadership positions that they're not used to, and are really challenged with this sort of, how do you create the right relationships, have the right conversations to move things forward. And I guess I wonder what support, I mean, it is, you do mention this in the paper, but I just want to emphasise the need for support in helping people diagnose what the issues might be before moving into contracting with any kind of intervention, and then implementation and review almost in each case. Because I think what we're asking people to do, I think, at CCG leadership level, is shift their thinking and their doing from where they were to where we're not quite sure where it needs them to be, and we're needing to encourage a very different type of leadership to the kind that they've experienced or delivered in the past. And I think that, if not so much a critique, but I think I'd like more emphasis on how we do that and how we measure whether we're doing it and what the interventions might be that are available. I still wonder about whether this has been, to what extent this has been truly jointly created with CCGs. I'm not, I can see it in the paper, but there's some, I can't emphasise enough how important it is that they are allowed to say, you know what, I'm really struggling with the relationship here, I don't quite know what's wrong, I need help to diagnose the problem across my local system and in my relationships, and then I need to, and that is, I think, will be critical going forward.
And just to comment on that, perhaps it's easy for me from the insurance point of view. I mean, certainly CCGs, I hope, have really great relationships with their area teams. It is clear that all have good relationships, but some are better than others.
Yeah,
and I think that in terms of that sort of day-to-day ongoing relationship, we shouldn't underestimate the degree of contact that there is between the average area team and its small number of CCGs on a very regular basis, which I think will put into place some of the discussions, informal discussions you're talking about to help to diagnose and identify where they get further support, even for those CCGs which are authorised without conditions. Plainly, the next more official or formal step to that is the CCG assurance process, and if, as you know, we're out consulting on that at the moment. The board's had a copy. We'll be talking about that at, I think, the next board meeting, and that will be the opportunity for CCGs to not have as comprehensive a process as we did in authorisation, but nonetheless to have a very significant process that allows us to look at the range of competence and ability, and then what's the sort of support the CCGs need.
Yeah. Okay.
Okay, thank you very much. Thank you, Ross. Let's move on then to item 16, which is the Genomics Strategy Board. Bruce.
Thank you, Chair. This paper is largely for information, but perhaps I could just give colleagues some background. So the subject of genomics, I think, has come of age. Many of you remember it's only a few years ago that there was a race to sequence the human genome. And since then, the cost of sequencing a human genome has dropped from well over $1 million down to about $1,000. The time to do it has fallen from months down to about a day. And our understanding of the human genome has increased quite significantly. And this provides a whole vista of new opportunities for us. First of all, for our patients, secondly, for academia in this country, and thirdly, for UK PLC. So for patients, it wasn't long ago, before if you develop breast cancer, for example, that there were only sort of 3 different types. Now there are well over 40 different types, and the treatment is targeted according to certain bits of genetic sequencing within the tumour, which means that different people get different treatments which are more effective for them individually. In the case of some types of lung cancer, the treatment is entirely guided now by the genetic sequence of parts of the human genome. But what we can do now is not just look at parts of the human genome, we can look at the whole thing. And that provides some big opportunities for academic colleagues in the United Kingdom, because it provides an opportunity to start to explore the human genome, specifically by linking what we see in the genome to the characteristics of individuals and diseases that they may or may not suffer from. And I think our NHS is particularly well equipped to take advantage of some of this, because we are one of the biggest integrated healthcare systems in the world. We have the ability to put things in place throughout our system which can bring economies of scale when it comes to trying to address some of these issues. So the Department of Health some time ago had started to think about this, had developed a human genome strategy group, and then to think about how we might start to configure services for delivering this, and this is laboratory services really that I'm talking about, And that since then, the Prime Minister threw out a challenge that we should be the first system in the world, or healthcare system in the world, to characterize 100,000 genomes. And we've set about that, and this paper describes really how we're setting about doing that, and who is meant to do what, with particular respect, I think, to the relationship between the Department of Health and NHS England. There are many details in the paper which I won't go into now, other than to say that Malcolm Grant chaired a board which looked specifically at clinical and patient engagement, informatics and data, and the kind of benefits realization that might be achieved from this. The Chief Medical Officer chaired another group with a series of work streams looking at the science, the ethics and data storage about this, and the paper really describes how these groups will work together in the future.
Yes, thank
Chair.
you very much, Bruce. And the current outcome of all of that is the establishment of Genomics England, which is a company limited by shares, but where the company will be chaired by Sir John Chisholm, former chairman of the Medical Research Council, and with stakeholder representation from the different organisations. Again, the critical thing is to get absolute clarity and accountability for this exercise, and for us to be clear about what are the deliverables for us as NHS England as a consequence of this investment. May I invite any other observations?
This stuff sounds like borders on science fiction, doesn't it? It's amazing. But are we, just to be clear, are we talking about the development of bespoke medicines and interventions for individuals? Because I wonder about some of the ethical issues around race, which I've read about in other areas, and whether that's been considered, because that has implications for resource allocation. I just wonder about whether that's something that's been thought about, or whether it will be thought about, because it has huge implications if that's one of the products.
It is indeed. One of Sally Davis's 3 working groups has had a very profound consideration. There are many ethical issues tied into this, about patient counselling, for example, and who owns the data and how it's used. So I think what would be best is if we can supply Victor with a copy of the report.
Really interested. Thank you.
Yeah, we do that.
I mean, this is, one can envisage, I think, the state of science in 10 years' time where patients will go out and get their whole genome sequenced, where it could be in the order of £100, £200 to do it. So they turn up to the GP with their sequenced genome. I mean, huge implications here for ethics, for counselling, for advice, for science and technology, and the training of our clinical professionals for the future. Tim, your cue.
Well, it was only just to say that one of the reasons why the Prime Minister and we should be excited by the opportunity, though very mindful of all the ethical issues, is because the NHS does have the opportunity to be a sort of to deliver a world-class data infrastructure, which is vitally. I mean, without the clinical reference data, you can't make sense of the gene sequences, and we are in a unique position to offer that to science. But there are many ethical issues in the offer. Quite apart from of the sort you're mentioning. So I would just say one of the reasons why we've got involved in this, we need to figure out, I think, very carefully what the cost implications of remaining and involved relate to the data infrastructure. So there's a whole piece of this that's all about just creating, maximising the asset value of the data that the NHS produces as a byproduct of its work.
Something like the time, isn't there? It's here. It's rapidly.
Yes.
Sorry, but it's.
No, I think it's potentially an enormous breakthrough for the benefit of patients, which is why we really would like to be world leaders in this, for the benefit of NHS patients, and that will be, I think, a major step forward. Well, thank you very much, Bruce, for that brief report. May we then move on to Jane for the 6Cs Live website.
Thank you, Chair. Members of the board will have some hard copies of slides, and we'll have some slides that other others can see. I'm going to go through these relatively quickly, but if we just go to the first slide, or the next slide, it talks about. This is about the 6 Cs. It's about our nursing vision and strategy. It's the one that's been agreed by multiple stakeholders and by nurses and midwives in the NHS itself. And I think we are all very, very clear that we've had quite a lot of negative publicity, bad news stories around the profession, the way in which they work, and that's been repeated on several occasions more recently. And I thought it was really important for the board to see what we're actually doing, what practical applications we've done to spread good practice and really engage with the nursing profession. So the next slide just talks a bit about what 6 Cs Live is. We look at it as it's almost like the engine room of the 6 Cs. It's about how we turn what is a vision and strategy into some practical reality, and allow, through having a sort of virtual communication hub, the ability for those that are delivering the 6 Cs to share their best practice, to be able to ask questions, to act together to really drive improvements. So I'll just take you through over the next few slides very quickly what it looks like. So if you go onto the 6 Cs Live website, which we launched 13 days ago, there's a welcome page. It describes what it's about. It discusses what the 6 Cs are and how people can access it. The next slide just highlights the registration point. It allows people to go on and register, to say who they are, where they work, what they want to do. The next slide shows where we have got the compassion in practice implementation plans. And the point about this is it means that anybody, anywhere that's got access to the internet can have a look and see what we're doing. So members of staff, members of the public can see what it is we're doing, what have we committed to, what are the timescales about that. The next slide highlights weeks of action. And what we really wanted to do was to be able to have some concentrated areas of effort where we picked a particular subject, something that people were keen to look at, hold webinars, share best practice, have people doing things like guest blogs or different discussing what it is they're doing, and really concentrating on an area that people can then pick up, take off and do and look at in their own local circumstances. The next slide highlights where we have a multitude of partner organisations who've signed up, and the partners that have signed up to this so far include people like the Royal College of Nursing, the Florence Nightingale Foundation, individual organisations, so individual trusts, individual community services, but it also has some of our key stakeholders like Health Education England, Public Health England, and people like Patient Opinion. So we've got the ability for Patient Opinion to both take information from our website and actually share it, and to feed into us different opportunities that we've got. The next slide highlights our desire to really celebrate success, and it's a careful balance for me between actually wanting to promote and share some of the really good work that so many people are doing in the NHS, but also recognising that it's not good all of the time everywhere, and we can't be complacent. We need to be driving that improvement, but at the same time really supporting staff actually out on the front line and giving them the ability to be proud of what they do and to show what they do well. And there is a real risk that morale just gets more and more battered by lots of bad news stories, and we want to try and balance that so that we can help people to improve, but also celebrate where things go well. And the picture up there is Matt Hodgson, who is a consultant respiratory nurse who works in London, who was the Nurse of the Year. And as part of that celebrating success, we're asking people to tell us their good news stories, tell us what they do. And we've got a panel, which Matt's included on the Nursing Times is. We've got Matt King, who's a patient champion. So we will be looking at all of those good news stories and identifying a story of the month, which we'll publish on our website and also will be published by the Nursing Times. We've also got a section in the next slide that shows our caremakers. I won't spend long on this, I've talked about them before. These are student nurses, newly qualified nurses, who are acting as our ambassadors of the 6 Cs. They are spreading that good practice. They're talking about it in their universities, in their clinical placements. Several members of the board have met the caremakers. They are incredibly motivated, inspirational individuals. Victor actually wore a caremaker's. He's got a caremaker's sweatshirt that he wore at Expo. So we've got a really good team there, and they are setting up their own part of the website, and we aim to have over 1,000 of those by the end of this year. We've also got, on the next slide, it just highlights that we've got a live Twitter feed. In the last literally 13 days, we've now got, not huge numbers, we've got 1,800 followers, but there's been about 224,000 Twitter impressions, so we're getting quite a lot of noise in the system, lots of people tweeting about different things. And then nearly there, the sign-up shows that people can pledge or become champions. So in the 13 days since we went live, we've had 1,703 people sign up to pledge to be part of the 6Cs campaign, 310 that have said they want to be champions. And those champions take a very active interest. There are details about them as individuals, and they really are out there promoting that really good practice. We have communities of practice that are there. So if you happen to work in a general practice and you want to see what the general practice nurses are doing, or you want to see what community nurses are doing, you can click onto that part and find out what those individuals are doing elsewhere in the country. And we actually have a map that talks about where we're going. So we say what's happening in different parts of the country. So where am I going, where am my team going, what events are being held all around the place that people can actually look at and log on to. And then we have patient and family stories. The ability for us to link back to what patients and families tell us that is good experiences that they've got around the 6Cs. And this helps us with our implementation in terms of being able to use those stories to perhaps be part of appraisal systems, etc. So the last but one slide really is some messages I wanted to give both to the board, but those watching. This is around disseminating the 6Cs to teams. It's about spreading it not only amongst ourselves in NHS England, but more widely out in the system. I'm encouraging people to sign up and pledge. You don't have to be a nurse to do it. Anybody can sign up and pledge to the 6Cs. The 6Cs are applicable to absolutely everybody. Asking people to blog if they want to. The website is there very, very, very clearly. And I'm going to end with the photograph of David, who actually launched 6Cs in Wolverhampton on July the 5th. Yeah, he didn't eat any of the cake. He just cut it. But he actually launched it and presented it to a group of staff in Wolverhampton on the 5th of July. And I think we've moved quite a long way since then, even though it's not a very healthy looking cake. But thank you very much, and I'm very happy to take any questions.
Jane, thank you very much. That's terrific. I think it just brings home to us again and again and again the sheer importance of nursing as a profession. It was brought home to us, obviously, with mid-staffs, with the KEO 14, if I could call them that, and, of course, Julia Neuberger's review of the Liverpool Care Pathway. I mean, I don't think the profession has ever had a higher profile and in need of the attention that you're giving in your professional leadership role. So I think we all appreciate enormously the 6Cs initiative, and we'll do everything that we can to support it. Kieran?
But remembering that
to celebrate all the fantastic stuff that happens out there every day as well, and I think that is the trick. It's how do we give fantastic people who do fantastic work the time and the space to do their jobs in the way they want to do them, and so celebrate the success, but also create the environment.
And that's a really key part of the compassionate practice strategy. There's a significant amount of work around creating the environment, the culture, the support to enable to enable staff. Staff to be able to give that care.
Yeah. At the risk of prolonging what is already a long meeting, I just wanted to make there's a connection, isn't there, between the work that Bruce has done and the 6Cs, in that those hospitals, I mean, the 6Cs in itself could be an intervention.
Yeah.
And it could also help accelerate, because you've got 1,000 people. I'm really interested in accelerating. The 6Cs should be a normative experience rather than a special programme. So it's how do we get there? That's the question, isn't it?
Yeah, and if the Liverpool Care Pathway story was that in some places there wasn't the care and compassion, you can change the pathway, but if you don't do this stuff, you don't get...
Exactly.
Exactly. So it all kind of feeds into itself.
Right, well, those I think are tremendously important messages on which to conclude the meeting. The only other item of business that I've got is to report that our next meeting will be here on the 13th of September. And the board will now go into private meeting. I'd ask you to support the appropriate resolution to do that and to bring to a close this public meeting. May I thank once again all the members of the public who have joined us today, and thank you for your patience in what has been a long but not dull meeting. Thank you. The meeting is closed.